Welcome back to PassPEBCwithMe. In this video, we're covering Chapter 2, Anxiety Disorders from Therapeutic Choices. Are you preparing for the PEBC exam and worried about memorizing all those anxiety meds? Well, you're not alone. Ironically, learning about anxiety disorders might just give you one. But don't stress, I've got you. In this video, we're diving into Chapter 2, Anxiety Disorders from Therapeutic Choices, and I promise, we're going to make it simple, high-yield, and not boring. Let's get into it. Okay, so what exactly is an anxiety disorder? It's not just feeling nervous before an exam or awkward at a party. That's normal. Anxiety becomes a disorder when it's persistent, excessive, and starts interfering with daily life, like your work, sleep, relationships, or ability to function. It's your body's fight or flight response, but stuck on repeat, without any real danger around. Think of it like this. Normal worry. What if I forget my notes? Disordered anxiety. What if I fail, lose my job, end up homeless, and ruin everything, all because your laptop froze for 3 seconds? In medical terms, anxiety disorders are a group of mental health conditions marked by excessive fear, dread, and physiological symptoms like sweating, rapid heart rate, chest tightness, or a racing mind. And yes, sometimes even panic attacks. There are many types, and we'll break them all down in a way that sticks for the exam and for your brain. The treatment of anxiety disorders isn't just about calming someone down. Nope. It's way more strategic than that. First, we want to eliminate or reduce the actual symptoms, like panic, restlessness, fear. Second, we aim to reduce anxiety-based disability so the person can live, work, love, and sleep without fear taking over. Third, we want to prevent relapse. Because treating anxiety once is great, but we want to keep it gone. And finally, we need to treat comorbid conditions like depression, substance use, or other medical issues that often tag along. Basically, it's not just about putting out the fire. It's about making sure it doesn't spark up again and removing anything flammable around it. Now, let's talk about investigations, the detective work before we start treatment. You don't just throw meds at someone and hope it works, you dig deep. Step 1. Take a detailed history. Ask about when symptoms started, how bad they are, and whether the patient is also dealing with other psychiatric or medical issues. Why? Because anxiety is often just one piece of a bigger puzzle. Step 2. Do a physical exam. You need to rule out physical causes like thyroid problems, heart conditions, or even substance use. Imagine treating anxiety with meds when the real cause is hyperthyroidism? Big mistake. Step 3. Order lab tests. CBC. A liver function. GGT. Thyroid levels. TSH. Go for the super sensitive one. ECG if needed. Pro tip. If there's a physical illness causing those symptoms, treat that first before calling it anxiety. You don't want to label someone with a psychiatric disorder if it's really a medical one in disguise. Okay, let's be real. Not every anxious moment needs a pill. Sometimes life just throws lemons and your brain decides to spiral. Here's what you can actually do before jumping to meds. Cut back on caffeine. Your double espresso might taste amazing, but it's basically anxiety in a cup. Alcohol? Nope. It's not therapy in a bottle. It might chill you for a bit, but it rebounds like a boomerang. Benzos equals emergency only. Think fire extinguisher, not daily smoothie. Use short-term, max 4 days. Chill out time. Try breathing exercises, meditation, or time blocking your schedule like a boss. CBT is the GOAT. That's cognitive behavioral therapy. It retrains your brain like going to the gym, but for your thoughts. If 2 antidepressants don't work, don't panic. It's referral time. A psychiatrist and CBT combo can seriously work magic. Now that we've calmed our minds, it's time to check out the med cabinet. Let's get into those pharmacological choices. And yes, we're spilling all the SSRI, SNRI, and benzo tea. Let's talk meds. Because when deep breathing and CBT aren't enough, it's time to bring in the big guns. First up, panic disorder. The main players here? Antidepressants. SSRIs are the frontliners. We're talking citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. These are your go-to choices, especially when panic comes with or without agoraphobia. They've shown solid results in reducing panic attacks. But here's the catch, they take time to work. So, don't expect magic on day one. Then there's venlafaxine, an SNRI. It's also proven effective in trials and works well for patients who don't respond to SSRIs. Now, let's talk backup options, the tricyclic antidepressants. Imipramine, desipramine, and clomipramine have been around for a while, and they're effective too. But they're not always the first choice due to their side effects. Need something even older? MALIs like phenelzyme and tranylcypromine can help, but they're tricky to use and require strict dietary restrictions. Important tip: when starting these medications, the dose should be as low as possible and increase slowly. Starting too high can actually make anxiety worse. And don't stop them abruptly. These meds are often needed for months or even years, and stopping too fast can cause a relapse. Now, let's look at benzodiazepines. These are not first line for long-term use, but in the short term, they can calm things down fast. Drugs like alprazolam, clonazepam, lorazepam, and diazepam can be used when someone presents with severe panic attacks and needs immediate control. But they come with risks, dependence, withdrawal, and sedation, so they're used with caution and usually only short-term. In short, for panic disorder, start with an SSRI or SNRI at a low dose, go slow, and be patient. Keep benzos in your back pocket only for acute situations. And always consider CBT alongside meds for the best long-term results. To the anxiety pool. And no, we're not panicking yet. Panic disorder with agoraphobia. This one's a combo deal. You've got panic attacks, and then you start avoiding places where you think panic might strike again. And that fear builds into agoraphobia. Treatment is very similar to regular panic disorder. You still start with SSRIs or SNRIs like paroxetine, sertraline, or venlafaxine. CBT is key, especially here because it tackles that avoidant behavior head-on. In fact, when agoraphobia is more severe, CBT might actually be more effective than when it's just panic alone. Social anxiety disorder, aka social phobia. This is not just shyness. We're talking about extreme, paralyzing fear in social situations, like giving a presentation or even making small talk. First-line treatment? You guessed it, SSRIs and SNRIs. Our champions here include escitalopram, fluvoxamine, paroxetine, sertraline, and venlafaxine. If the anxiety hits during performances, like stage fright, a single low dose of propranolol about 30 minutes before the event can calm things down fast. And don't forget CBT. It's especially powerful for social anxiety, sometimes even more effective than meds alone. When first-line options, specific phobia. Scared of snakes? Heights? Needles? Don't worry, you're not alone. But here's the twist. Medication usually isn't the answer here. Instead, CBT, especially exposure therapy, is your best friend. Just 6 sessions of CBT can create a huge shift in how someone responds to their phobia. So no need to pop pills here. Just face your fears one baby step at a time. Obsessive-compulsive disorder, OCD. OCD isn't just about washing hands or checking locks. It's a deeply distressing disorder that can start in childhood and seriously affect quality of life. For meds, the top SSRIs are fluoxetine, fluvoxamine, paroxetine, and sertraline, all at higher doses. CBT, specifically with exposure and response prevention, is the cornerstone of treatment and often combined with medication. Clomipramine, a TCA, is also very effective, especially in treatment-resistant cases, though it comes with more side effects. For those not responding well to SSRIs alone, augmentation with risperidone can be considered. Fun fact: OCD is one of the few anxiety-related disorders where medications might take up to 10 weeks to show effect. So, patience is key. Post-traumatic stress disorder, PTSD. PTSD can show up after a serious trauma, like an assault, war, or natural disaster. And it's not just flashbacks and nightmares, it's a full-body response: emotional numbness, hypervigilance, and sleep disturbances. Here's what works. SSRIs and SNRIs again lead the way: fluoxetine, paroxetine, sertraline, and venlafaxine. Other helpful options: mirtazapine, moclobemide, and bupropion. Atypical antipsychotics like risperidone and olanzapine can also be used as augmenting agents when first-line therapies don't work alone. Important note: benzodiazepines are not recommended for PTSD.
Why?
Because they can worsen symptoms like dissociation, and there's a high risk of misuse. Alright folks, we've made it to the last leg of our anxiety adventure, and trust me, this one's super high yield for the PEBC exam: Generalized Anxiety Disorder, or GAD. So, what exactly is GAD? It's that never-ending loop of worry about health, money, work, family, or literally anything that just won't shut off. It's excessive, uncontrollable, and sticks around for months. And let's be real, everyone worries, but GAD takes it to a whole new level. These patients often also show signs of depression and physical symptoms like restlessness or trouble sleeping. That's why CBT, or cognitive behavioral therapy, is considered the most effective psychosocial treatment. But here's the twist: it takes time, like 20 or more sessions, to really start making an impact. Now onto the meds. Our first-line heroes are the SSRIs and SNRIs. Leading the squad are escitalopram, paroxetine, sertraline, venlafaxine. These have all shown great results in trials. But what if your patient doesn't do well with these? That's when we call in the backups. Imipramine, a TCA, useful but risky if overdosed. A pregabalin, often used if first-line options fail. Bupropion, another alternative, though not always first choice. What about benzodiazepines? They can help, for example, alprazolam, bromazepam, diazepam, or lorazepam, but here's the catch: they're for short-term use only. You've got to watch out for dependence and withdrawal. That's why they should never be stopped suddenly and why they're used cautiously, especially in long-term GAD management. And here comes a lesser-known player: buspirone. It's like a calm cousin of benzodiazepines. Less sedating, lower risk of dependence, but it's slow. So don't expect it to kick in like a shot of espresso. It's best used when transitioning off benzos to avoid withdrawal symptoms. Therapeutic tips. Let's keep it real. 1. Start with short-term stuff. Sometimes relaxation techniques and therapy can work wonders, especially in milder cases. 2. Switch it up if needed. If one antidepressant doesn't work, don't panic. Just switch to another within the same class, like SSRI to SSRI. 3. Still not working? Then try something from a different class. Maybe it's time to go from an SSRI to an SNRI, or even something like mirtazapine or bupropion. 4. Limit benzodiazepines. Only use them short-term, 6 to 8 weeks tops, and only to manage agitation caused by antidepressants. You did it! That's a wrap on Chapter 2, Anxiety Disorders. We covered goals, investigations, therapies, all the meds, and every tiny PEBC-worthy detail. Coming up, don't miss the quiz shorts based on this chapter. Test your memory and drop your answers in the comments. I reply to everyone. Got doubts? Post them below. Want more chapters? Hit that subscribe button. Like the video if it helped, and share it with your study group. Let's crack PEBC together, one chapter at a time.
See you in the next one.